Thank you for joining us as we approach a historic election where health policy has really played an important role. I think it's a really good time to talk about the politics behind health policy, which is what this panel is about. So we're bringing to you 4 experts to talk about this. I'm going to briefly introduce them, then each of them is going to say about 5 minutes worth of great thoughts, and then we'll take your questions. So you can type them in using the Q&A, and we'll try and get to as many of them as we can. So without further ado, let me introduce our panelists. We have Lawrence Brown, who's the proud grandson and son of Mississippi and Arkansas Delta sharecroppers and preachers. He holds degrees from Morehouse College, the University of Houston, and the University of Tennessee Health Science Center. In June 2018, he was honored by OSI Baltimore with the Bold Thinker Award for sparking critical discourse regarding Baltimore's racial segregation. His first book, The Black Butterfly, The Harmful Politics of Race and Space in America, will be published by Johns Hopkins Press in January 2021. Ilyana Kuziemko is a professor of economics at Princeton. She holds degrees from Oxford and Harvard universities. Her research focuses on economic inequality, specifically on voter preferences for redistribution and the effects of US public health insurance programs on vulnerable groups. She served as Deputy Assistant Secretary for Economic Policy at the US Department of the Treasury from 2009 to 2010, where she worked primarily on the development and early implementation of the Affordable Care Act. Nolan McCarty is the Susan Dodd Brown Professor of Politics and Public Affairs. He holds degrees from the University of Chicago and Carnegie Mellon University. His research interests include US politics, democratic political institutions, and political game theory. He's co-authored 3 books: Political Game Theory, Polarized America, The Dance of Ideology and Unequal Riches, and Political Bubbles, Financial Crises and the Failure of American Democracy. In 2010, he was elected a Fellow of the American Academy of Arts and Sciences. Paul Starr is Professor of Sociology and Stewart Professor of Communications and Public Affairs at Princeton. He holds degrees from Columbia and Harvard University. He's the author of 10 books, including 3 about health policy. The Social Transformation of American Medicine won the Pulitzer Prize for Nonfiction and the Bancroft Prize in American History. The Logic of Healthcare Reform, which sets out the basis of what became the 1993 Clinton Health Plan, and Remedy and Reaction, America's Peculiar Struggle Over Healthcare Reform. So I'm sure you'll agree they're a very good panel to talk about this. So Lawrence, would you like to start and set things in motion?
Sure, absolutely. Thank you for the invitation, and I'm excited to be having this discussion today. I guess I'll start by saying that I've had 7 of my family members who've contracted COVID. So this pandemic is beyond an academic exploration for me, is very personal. In June, my grandparents contracted the virus. Thankfully, they both survived. And so when I think about health policy and the way that the election is shaping up to this point, I think about that through the lens of my family's experience and experiences of those in the African-American community. And I think what we've seen so far is really a complete failure of the federal government in terms of addressing the issues as it relates to this virus and the pandemic. And beyond that, it's sort of interesting how the way the pandemic has unfolded. In the first wave, of course, you had the introduction of the virus into California's Seattle nursing homes. And then in the second wave, you had large urban areas hit really hard, particularly hyper-segregated cities such as New York, New Orleans, Detroit, Milwaukee, and they were just slammed really hard by the virus. And I think we saw that the political response was one that regarded the people that were being hit the hardest at the time were African Americans, Latinos living in red-lined communities in the middle of these hyper-segregated cities in America. And so the federal government was slow to respond. And in fact, when health disparities data were released around April or so, and it was known, or it was stated that, hey, this virus is impacting African Americans, Latinas more, that's actually when many states decided they were either going to reopen or that they were going to stop taking some protective measures. And so for me, the politics of COVID have everything to do with how race and space intersect and interact in American political society and in our system. And so I think what we've seen is moving forward, of course, after Memorial Day, when George Floyd was murdered by the Minneapolis Police Department, the other pandemic impacting African Americans began to unfold. And so by a week after his murder, there were protests, riots, uprisings taking place all across America. And that too had political implications. You saw some polling that said that Black Lives Matter was more popular or had more support than it ever had before. So these twin pandemics for Black communities, I think, has had a large motivating force as it relates to the election that we're in right now. And of course, both of these pandemics, I think, are really built on top of the foundation of what Princeton scholar Douglas Massey and his colleague Nancy Denton called American apartheid. So it's American apartheid that really is not only the platform upon which COVID and police violence have been sort of staged and then launched in America, it's also the case that American apartheid, and we're talking about segregation in urban areas and suburban areas and then beyond in rural areas, it's also impacted the political system and the way that we sort of see everything as it relates to the election. So we're talking about gerrymandering, the political boundaries drawn around race and how people are clustered in American society, and which of course has impacts in terms of who's elected to Congress, how laws are being shaped, who those laws are being shaped for, who those laws benefit. So, American apartheid is really at the root of America's political and social and health-related conundrums right now, the crises that are proliferating through our society. American apartheid is at the root. So I'm looking forward to this discussion, to hearing more about how we understand the way health policy is really in so many ways shaped by American apartheid at its root.
Thank you. Ilyana. Oh, you're muted.
I'm going to be sharing my screen if that's okay. Can everybody see my screen? All right. So thank you so much for having me. Thank you, Lawrence, for starting us off. It's absolutely clear in the statistics that racial minorities in America are overly represented among COVID cases and COVID fatalities. I'll be talking about another group that is overrepresented, which is the elderly, which is no surprise. I'm sure all of you know that this is a disease that to which the elderly are especially vulnerable. In general, I'm going to make the argument that until 2020, health policy was a key reason that the elderly vote was very hard for Democrats to attract. And so my question for the next 5 minutes will be, is 2020 different? So let's just take a moment to think about the elderly vote pre-COVID. So let's say up till 2016, just to set the baseline. The over 65 vote has moved toward the GOP over the past several decades. And you can see this whether you look at just data on people saying, what party do you belong to, or exit polls asking people how they voted in elections, like presidential elections. So in some past work, I've argued that, and I'll show you some of the main arguments for this claim, that a major reason that this has happened, that elderly have moved in the Republican direction over the last few decades, and especially in the last decade or so, is that seniors are wary of health reform, and the health reform that they see coming from the Democrats in particular, which is to make coverage more universal. And in particular, and I don't think they're necessarily wrong about this, they worry that these expansions in public health insurance will come at the expense of Medicare. One way you can think about it is that for them, just literally speaking, already beneficiaries of Medicare, the over 65 population has access to Medicare already. Medicare for all is literally Medicare for others. And so, you know, this sign sums up what I think a lot of their fear is, which is that Medicare will be rated to help expand public health insurance to other people. So you can just see, just sort of seeing this trend. And again, looking at the exact timing, this is measuring party IDs. So this is the share of people who say in a survey, I am a member of the Republican Party, identify with the Republicans. So you can see for the most part, you know, the elderly and non-elderly moved together. George W. Bush was popular, then he was not popular. But right around the time that health reform becomes a major realistic topic in the Democratic primary in 2008, and then of course, when Obama passes the Affordable Care Act in 2010, these two numbers just never come back together. So there was a small elderly advantage toward the GOP before 2008, and then it just really expands to something quite substantial after 2008. And then just to see this movement, again, this is over a longer time period. If you go back to the 1970s, there's no real difference between the way the elderly and the non-elderly answer questions about expanding public health insurance. So this question that you can use any number of questions, but this question particularly asks, you know, should the government help citizens pay for medical bills? And at the beginning of this period, the elderly are actually more likely to say yes. And this just, you know, is declining across time, whereas the rest of the population, if anything, it's become slightly more popular. So, you know, this is clearly a major issue where the elderly and the non-elderly have parted ways. Okay, so that's sort of the longer term relationship between, you know, age and political affiliation. What's happened more recently? So older voters, as some of you might already know, were key to Trump's 2016 surprise victory. So this is the blue, the percent for Clinton of all the different age demographics. This is the red, the percent for Trump. And this is the percent of the electorate that's in each age group. So obviously these older voters, in part because of high turnout rates, in part because of the large baby boom population, are a very important share of the electorate, and they are going, you know, in large numbers for Trump. And this is, you know, this is not the first time this has happened. We also saw this with Romney. And then even if you look within Democrats, so these are seniors who are still Democrats, within the Democratic Party, candidates who push for universal health care, namely Bernie Sanders, do terrible with this demographic. So Sanders, even though he had some big victories in states like Nevada, he never wins the older votes, even among Democrats. So what's happening so far in 2020? We all know health and health policy are probably the most important question right now because of COVID. The elderly, not surprisingly, are very concerned about COVID, more concerned than any other age demographic. This is the bright blue color is the share that says, you know, COVID is the most important, the coronavirus outbreak or COVID is the most important topic to them, you know, outweighing the economy, outweighing Supreme Court appointments, you know, which we just had. So this is a really important group, a really important topic for the elderly for obvious reasons. Obvious reasons being that 80% of the known COVID deaths so far are coming from the elderly. And then you really get a sense, this is, you know, if you have a chance to read some of this personal testimony of an elderly voter who was so excited about President Trump and just feels betrayed. He knows people in his family who have died, as many elderly people have friends who have died, and just feels like he cannot believe how Trump is abandoning him on this issue. He was going to be great, except for COVID. So just a few, this final last slide, I'll sort of leave you with some questions. It's not just this one particular person that we saw in the in that testimonial. Seniors are leading the backlash to Trump. So Trump is doing poorly relative to his performance in 2016 among all demographics. But he is, the elderly, who were a huge part of his victory, of his coalition, are just turning against him to the point where they're now, if you take the latest numbers from 538, he's now slightly underwater with them. Florida, which is such a key state, I mean, we're all going to be wondering what happens to Florida on Tuesday. It's also one of the oldest states in the country, with all the retirees that moved down to Florida. There's been, according to the latest NBC poll, a 24-point swing against Trump relative to his performance in 2016 with the elderly. I mean, it's just a crazy, if he loses Florida, which is key to his election, map, it'll be because of the elderly, it seems. So the key open question to me, as someone who thinks about how health policy affects party alignment and redistributive preferences, is, I'm so sorry. Is this going to last, or is this just a blip? I mean, hopefully COVID's not with us in 4 years. Will this create lasting mistrust among this important demographic about GOP competency, or how much they care about the elderly? Is this something that Democrats can use in future elections, or is this going to return, to the longer baseline trends?
Great questions. Thank you, Ilyana. Nolan. Oh, you're muted, Nolan.
Great. Thank you. Thank you for having me on the panel. I'm not really a health policy scholar, but rather a political scientist who focuses on trends in the policymaking environment. So I want to talk a little bit about some of my ongoing research and kind of link it to what I think is kind of a central role in several trends in terms of understanding the poor governmental response to the COVID-19 pandemic. One of my central research concerns over the past several decades has been the rising levels of political polarization and partisanship in the United States. Over the past 40 years, the levels of substantive disagreement and general animosity between the parties have been growing, especially at the national level. We see this in Congress, the House, the Senate, the presidency. We also increasingly see it among voters. But more recently, I've been focusing on the levels of polarization within the U.S. states. There too, we've been seeing rising levels of partisanship within the state legislatures. So the difference between Democrats and Republicans in California have been growing. The difference between Democrats and Republicans within Alabama, Texas, any of the states, those partisan differences have been growing at an accelerating rate. But there have been another set of important trends affecting the states. In particular, there's been a growing tendency for state governments to become controlled by a single party. So there are many more completely Republican-controlled state governments, many more completely democratically controlled state governments. We don't see the levels of divided government or divided legislative branches that we once saw. There's been a partisan consolidation in most states. So if you combine the partisan polarization, the differences between Democrats and Republicans growing, and partisan control of the states growing over time, we have something that I've called federal polarization. The ideological and partisan differences across state governments are, as far as I can tell, at an all-time high. Okay. The first implication of this is that policy, whether it's health policy, policy with respect to marijuana, environmental policies, criminal justice policies, are all starting to diverge across Republican-controlled states and Democratically controlled states. So we're seeing a much stronger match between the partisanship of the state government and the policy mix that the state adopts. Now, one could say that's what federalism is supposed to do. We should give voters the opportunity to have policies which match their policy preferences and their partisanship, etc. But I'll argue in the case of COVID-19, this has been an unmitigated disaster. Okay. So we start with, I think, the pretty uncontroversial statement that we've had poor policies come from the national government. The national government under Donald Trump failed to fully use the powers of the federal government to coordinate a response to COVID-19, refused to use the Defense Production Act to buy the necessary protective gear, the medical supplies that were needed to combat it, and failed to use the powers of the persuasion of the presidency in order to encourage proper public health measures such as masks and social distancing. So we start with a situation where we get an absence of a clear federal response, which leaves it to the states to coordinate the response. So states are ill-equipped, naturally, to do this. It requires a fundamental level of coordination, especially as we see in the Northeast, where all the states are pretty small, close together. You can't have separate policies for a lot of these areas. There are lots of competition among states for resources that the federal government should have been able to provide. But at the same time, it becomes an opportunity. These federal-state divides become an opportunity for the president to politicize the crisis and to put the blame for the crisis on the shoulders of Democratic governors instead of where it belonged at the national government. So this was helped along early in the process by the fact that the crisis hit blue states first. So it was easy for a Republican administration to say it's because of the lousy policies of Chris Cuomo and Phil Murphy, and not to take the kind of federal responsibility. And this ultimately percolated down to voters who began to see the response to the crisis in partisan terms, turning basic public health measures such as masks and distancing into partisan litmus tests. Now, I think there would be a partisan ideological difference in the uptake of masks and social distancing, the prioritization of reopening versus lockdowns, absent the overt politicization that the president engaged in. But we have it. And I think that was exacerbated by the fact that the president could play blame game politics against governors of the blue states. And then at the same time, encourage governors of red states to reopen early in order to send a signal that the crisis was not to be taken seriously and that it was under the control of the federal government. So this kind of overt politicization is a kind of natural outgrowth of this federal polarization. I think the scary part, I think, of my analysis is that while we may get a new president on Tuesday, of course, that person won't be the president for another 6 weeks. I'm sorry, another 12 weeks after that. We won't be able to replace the federalism. We'll still have the federal polarization. We're still going to have a politicized response to the crisis. The public health measures are still going to be highly correlated with the partisanship of the state. And it won't take away the opportunities of kind of red state governors to challenge the federal response, to make it difficult. There are certain areas in which the federal government can act and will act, but there are certain areas in which coordination and cooperation with the states are essential. So one of the issues, for example, is that it's unlikely that Biden has the power to institute a national-wide mask mandate. Due to federalism and the kind of local nature of public health responses, and this kind of federal division across states will continue to be with us, and we'll expect that that will be a real challenge for getting the COVID crisis under control, irregardless of who's elected on Tuesday. Thank you.
Thank you, Nolan. Paul.
Thank you. These have been three such interesting and such different presentations. I'm going to raise a fourth set of issues. In fact, I'm going to make a prediction. I think this is going to be the seventh and last election in which the Affordable Care Act hangs in the balance. The seventh election, because going back to 2008, when it was not yet named, but central question as to whether first Hillary Clinton and then Barack Obama would pass a large scale health insurance reform. And then beginning in 2010, counting both the presidential and midterm elections, Republicans have been promising to overturn it ever since. Now, why might this be the last such election? Well, of course, it could be because the Supreme Court might might overturn the act. It's possible. I don't think it's very likely in the end. But I do think the decision could actually help resolve the issue in some way. So what do I mean by that? So as you know, the court this next month is taking up for the third time the question of the constitutionality of the ACA, this time because the tax was eliminated in the 2017 Republican tax legislation, but the mandate is actually still in place. And the opponents of the law now say the whole law must be overturned as a result. I think it is very possible that the court will vote to overturn the mandate, that specific provision in the law. Whether they will then go on to use that as a basis for overturning the entire law, I think is doubtful. Now, that could happen. If you go back to the 2012 decision, the four dissenters, in the opinion written by Justice Scalia, the four dissenters would have overturned the whole law on the basis of the mandate. And it was Justice Roberts who then upheld, by voting to uphold the law on the basis of the tax, who prevented that from happening. So now, of course, Amy Coney Barrett replaces Justice Ginsburg. Perhaps there is a majority for overturning the law as a whole. However, I think there are a couple of reasons to believe they'll hold back from that. One is that the court itself faces a problem of legitimacy, and whether they would be really willing to spend their political capital, such as it is, in overturning this law and then effectively denying health insurance to some 21 million people. I wonder whether they will be willing to do that. There is a very strong case for the severability of the provision of the mandate from the rest of the law, and I think I think even some of the court's conservatives will come to that judgment. But even if they don't, the oral argument may well signal what they are likely to do. And if Democrats win this coming Tuesday, that is both houses of Congress as well as the presidency, they could moot the entire case with a one-sentence piece of legislation or part of some other bill. And they could do that in one of two ways. One is simply to restore the tax. They could restore the tax, and that would take us back to the situation that existed before. That would moot the case. The other direction they could go is to eliminate the mandate itself, which is now a nullity without the tax. And I would actually favor eliminating the mandate. We now see that the Affordable Care Act works pretty well without the mandate. It may not work quite as well, but what drives enrollment is the subsidies. And there's, I think, if Democrats control Congress, a willingness to increase those subsidies to make them even more attractive. The mandate has been the chief basis on which Republicans have opposed it, and which they've called it unconstitutional, but also it's the basis of a lot of popular opposition. You could have a kind of resolution now without the mandate. The Republicans would in effect be able to declare a certain kind of victory themselves, and Democrats would have the Affordable Care Act as it is in fact now functioning. That could be the resolution on which this finally settles, and we move on from these disputes about the foundation of the Affordable Care Act to other kinds of issues. Now, if I can go on just very briefly about what I think Democrats ought to be considering from the standpoint of insurance reforms. There's been a lot of discussion about the public option. Biden has a public option as part of his proposals. I don't actually believe that in the final version that the public option would likely to take coming out of Congress, that it will make nearly as much difference as many people believe. And that's likely because a public option in the marketplaces is likely to suffer from adverse selection. If it has to negotiate rates rather than just use Medicare rates, it's not likely to enjoy the favorable position that Medicare has. A whole variety of reasons. I don't really expect the public option to be as much of a difference as many other people do. Now, Biden has also said that he wants to use the public option for enrollment of low-income people in the states that have an expanded Medicaid. And I'm not sure, perhaps somebody else here has an idea how you do that without disincentivizing the remaining states from adopting the Medicaid expansion. And that seems to, but perhaps it can be designed in a way that at least the providers in those states would really prefer to have the states carry out the Medicaid expansion than have the public option, maybe. The other provision in Biden's proposals that hasn't gotten that much discussion is his idea of expanding Medicare, making Medicare eligibility at age 60 instead of age 65. Now, this relates to what Ilyana was talking about. This is a kind of expansion of coverage, which I think seniors are going to accept. I think it's certainly something that AARP is not going to oppose because they consider everybody over age 50 to be a member. This is something I've been arguing for a long time, that the direction of Medicare expansion should be down to age 60 or possibly age 50. I was on a committee at the National Academy of Social Insurance on this and became persuaded the simplest way to do this, to expand Medicare, is through a simple change in the eligibility age. You'll get about a third of the people in that age bracket from 60 to 65. The remaining ones are likely to keep employer coverage. It's very manageable fiscally, and it will be a kind of demonstration of what happens with Medicare expansion. I think this is a group that also can benefit very substantially from this expansion, and it could be, it turns out, I think, perhaps more important than the public option in the exchanges. Now, one thing that I particularly like about expanding Medicare down to age 60 is that it is, in effect, a shot across the bow of the providers, because it will mean more people being paid at Medicare rates. We need to have some discussion, in my view, not about Medicare for all, but about Medicare prices for all, about expanding the application of Medicare prices. And that may not be at current Medicare rates. There may need to be some compromise, but the system that the Medicare market has worked on, both public Medicare and the Medicare Advantage plans, that structure has worked much better than the rest of the healthcare system. And one of the advantages of that system is that those Medicare rates constrain the rates the Medicare Advantage plans have to pay. And that we need to have some kind of mechanism, it seems to me, for extending that kind of discipline to the rest of the marketplace. I'd hope that this gets some discussion in a new era that we might be entering on Tuesday.
Okay, well, on that optimistic note, let's go to some of the questions which have been coming in. So, Ilyana, one question is for you, which is, do you see, given sort of the facts on the ground, constituency, a viable political constituency for a universal health program of some sort?
So let me say that I agree with a lot of what Paul just said about Medicare prices will probably, I mean, that's the most important part in my view for Medicare for all. Like if we can't have Medicare for all, Medicare prices for all would be a really nice consolation prize. I mean, I think this would be, if there's ever a moment to question whether our system of employer-sponsored insurance is humane and efficient, now would be the time, right? I mean, people are losing their employer-sponsored insurance left and right because of COVID, and yet that hasn't really been raised. During the Democratic primary, Biden was a staunch supporter of keeping employer insurance as sort of the backbone of the system. And so, I think had Bernie won, this would be naturally, he'd be using COVID as a way of saying like employer-sponsored insurance should go. I don't see that. I mean, I think if anything was ever going to happen, it would be now. And so maybe we are back in the world of, I think lowering the rate to 60 would be fantastic. I think, like Paul said, it'd be a nice demonstration. It would save money for the economy because the prices are lower, even if it would make it more expensive for the federal government. Yeah, so I think it just didn't come together. We don't have a Democratic candidate who's questioning sort of the fragmented nature of the US system. And so even though I think COVID would be sort of the ultimate time for that to happen, I guess I don't see it happening right now.
Okay. Lawrence, you mentioned in your remarks that, well, you didn't put it quite this way, but basically it took a really long time for the data on the racial disparity to come out. People were talking about this, but there wasn't any hard data for quite a while. And then once we got that data, I believe you're somewhat critical of what has been done with it. Can you explain that?
Sure. I mean, I think that, I think Paul mentioned the politicization, or the earlier presenter mentioned the politicization of COVID. And I think a lot of that centered around race, that when, initially when things shut down back in March and early April, there was some degree of national solidarity where that potentially we could all be in this together. But when it was revealed that, hey, these health disparities are revealed, and Black people and Latinx folks are the ones that are mostly impacted, you saw the governor of Georgia, rush to open back up when many of the essential workers and many of the service workers in other southern states are African American and Latinx. So I think that's the point when America stopped being serious about actually controlling the pandemic, when it became clear that more vulnerable people were going to be impacted. And so I think, this discussion about whether it's, Medicare for all or the Affordable Care Act, this is actually the discussion about who we are as a nation. Like, this is the time, if there ever was any, to move in a direction for universal health care. It's time to move in a direction, Medicare for all, particularly because Americans of different stripes are being impacted. First, it hit blue cities and blue states, but now it's in those red states. And the folks in the rural areas, predominantly white, they're being slammed. North Dakota, South Dakota, Milwaukee, Wisconsin, these Midwestern Sunbelt states are being slammed by COVID, and we have not seen the worst of it. The flu season is coming. This is going to be a dark winter, as the vice president candidate, Joe Biden, said. It will be a dark winter. Hospitals will be overrun. And so this notion of piecemealing a response to radical problems, I think, is ultimately foolish. The only way you're going to deal with radical problems is radical solutions.
So Nolan, kind of building on one of those points, our colleague Alan Flinders says he thought, wrongly it turns out, that Trump and McConnell's attitudes towards the pandemic would change when it started hitting red states instead of blue states. Why hasn't that happened?
I think that's a good question. I think I had a similar prediction, back in March and April. I mean, part of it could be due to the issues that Lawrence raised, that even when it's hitting red states, it's not necessarily hitting the constituents of the Republican Party in the red states, but hitting minority communities, lower income communities, not the kind of, if you think about the kind of typical local constituency of Republican politicians, it's local business people. They really wanted to reopen. There was a lot of pressure coming from those constituencies to Republican politicians. And then the pressure coming from the Trump administration to push reopening is a political signal to suggest that the pandemic was under control, that the economy would come roaring back, that we're turning the corner, whatever it is that we're supposed to believe today, put them in quite a bind. The Trump administration can't really do a turnabout in its response without admitting that its early response was mistaken. Donald Trump is not a person who likes to admit to ever being mistaken, but I think any presidential candidate would have a hard time reversing course on a major policy approach this close to the election. So the optimistic thing would be once the pressure from the Trump administration on local Republican politicians is removed, they might take more constructive steps toward keeping their states healthy, and but that's just something we'll have to see. My more pessimistic prediction is that the pressure from the local business community to keep things open and not to do another shutdown will keep the pressure on Republican governors to not change course and to kind of fight the Biden administration on future lockdowns or other kind of mitigation policies.
Paul, you're, I think, strongly identified with various Democratic approaches to health policy over a long period of time. So what a question that comes up is bipartisanship worthwhile? We've heard a lot of discussion that, it isn't, and the various parties should just use power when they have it. What do you think about that in the context of health policy?
It would be worthwhile if it were feasible. And really, when I think back to the experience that that I had, I think Alan Blinder just asked a question. He can remember this as well. At the very beginning of the Clinton administration in early 1993, we tried to work and expected to be able to work with Republican members of Congress. There was a considerable hope that we could pass bipartisan health legislation, that we were in active discussions with many of the trade groups, business groups, and so forth. And really, one of the key episodes in the recent history of polarization is what happened during the debate over the Clinton health plan. A key moment was in late 1993, when Bill Kristol wrote a memo to Republican members of Congress, saying that the party would be better off if all health reform were defeated and Clinton was really humiliated in the process. And that view came to prevail. And we saw the same thing happened in the course of the debate over what became the Affordable Care Act. After all, the basis of that lay in old Republican ideas. The individual mandate originally came from Republicans. It was an alternative to the Democratic idea of an employer mandate. The whole model for the Affordable Care Act really was so much influenced by Governor Romney's plan in Massachusetts. So really, there should have been opportunities for bipartisanship. The actual content of the ideas lent themselves to bipartisanship. But the Republican Party has not been open to cooperation in recent years. So as much as I think that would be desirable, I don't really think it's going to be possible. And let me just say one thing that connects to this whole discussion about COVID. Now, if you look back in the history of epidemic disease, if you look back in the history of vaccines, there was no partisan division, let's say, over the polio vaccine. There was no partisan division over most of these issues through most of the 20th century. But it begins to open up in the same period that these other divisions take place. So if you go back to what happened with the H1N1 virus in 2009, there's a fascinating study by Matt Baum of Harvard about how Rush Limbaugh and other conservatives stirred opposition to the flu vaccine that year, and how, in fact, there was a significant difference in the rates of vaccination and mortality from the flu between red states and blue states. I mean, this is, and you can see it in the anti-vaxxers too. Many things have been politicized that used to be outside of partisan divisions in this country. I wish it weren't true. I hope we can go back, but this is the reality we have.
Okay, one of our questioners sort of reminds us, even though we've been very focused on US politics here, that US politics actually matters for the rest of the world as well. Things like family planning programs abroad, the US withdrawing from the World Health Organization, the refusal to cooperate with other countries with in the development and eventual dissemination of a COVID vaccine. So a question is, does anybody think that the COVID policy or the COVID disaster is going to affect US attitudes towards internationalism and international health policy?
I can jump in and say, I don't know about US attitudes, but I have to, I mean, I'm American, so I don't have this perspective, but I have to think it reduces our prestige and whether people even want to listen to us. I mean, I even on that meta, and I'm very curious, the next panel, I'll tee up this question for the next panel, because you're thinking more about the health policy side and less about the politics, but I've been underwhelmed by like the response of the US medical technology sector in developing, and I would love to be shown evidence that I'm wrong, because I'd like to have some more optimism, but so I'm not answering the question directly, but I just think this whole episode, not even just the most embarrassing things like Trump not wearing a mask, but also the response of like what was supposed to be cutting edge, which is our medical technology sector, has been shown to be wanting. So I have a very pessimistic take that even if we want to re-engage under Biden, why should anyone listen to us?
Let me just weigh in. The partisan division on the role of international organizations and the role of the U.S. in cooperating with them has been large and growing for some time. A lot of skepticism on the right about the role and the purpose of international organizations. And unfortunately, the COVID crisis just reinforces those partisan divisions. The president, again, is playing blame game with everyone, so playing blame game with the WHO seemed to have come naturally. And instead of suggesting that what the U.S. should do is to tighten its links to other countries, to international organizations, he blamed the WHO for covering up for the Chinese and essentially blaming them for, bringing the virus here. So my guess, based on how the public has responded to other shocks like the financial crisis, other things that could have brought people together in terms of common understandings, it's going to have the same divisive effect. Right-wing voters are going to believe that international organizations are as nefarious as ever. Progressive voters are going to think they're more important than ever. And so it's going to be the balance of that polarized opinions that's going to determine the way in which the U.S. can continue to navigate with such organizations in the future.
Yeah, I'd like to mention that I think there's, as it relates to international policy, I think we have to remember the way in which the United States government has often functioned in a very negative way in countries. You think about the experiment in Guatemala with the men there with syphilis. You think about the program to capture bin Laden was a fake vaccination program, which actually would cause a lot of mistrust. So it's not just, Trump and the way that I think the way that people are responding to American foreign policy as it relates to health right now. America has been engaged overseas, not to mention, drone strikes, bombs, wars, military installations. These all have health impacts. So, health policy is not isolated in some sort of, cubicle. America policies overall has an impact on health, and specifically health programs like the ones in Guatemala or the one in Pakistan had an impact on how American health policy is viewed globally. And I think I want to go back to what Paul was saying about the idea that, partisanship now is sort of having this impact on health policy. But I think our partisanship is having this additional impact. But if you look at the difference between the crack cocaine epidemic and the opioid epidemic, there was very much, if not partisan, a very racialized response to those different pandemics. And so I think, that's one thing that we have to consider, that, the way in which America responds to health has always been politicized. and especially racialized as well.
But the course of the opioid epidemic is actually geographically so similar to the course of the COVID pandemic. Beginning chiefly in cities, beginning among African Americans and Latinos and so forth, and then moving now to rural areas. It's a very similar trajectory, and we have seen a shift in attitudes about opioid addiction. We haven't yet seen the shift, as we've been talking about on this issue, but maybe that's where the geography will eventually have a political impact.
Okay, I have to jump in on that myself, in that I think there may be some confusion. The opioid epidemic actually started among whites, and that, I think, is one reason why Lawrence is saying that there's been so much of a sympathetic response, right? So you have Chris Christie and people like that saying, oh, we need more treatment, because they're talking about white opioid addicts and not Black cocaine addicts. So I think.
Okay, yeah, well, it's the word, I think, but.
Yeah.
No, I was going to say the same thing, Janet. Only like in the last few years can you see any sort of overdose deaths among African Americans increase. It was very white to start. Sadly, it's becoming a bit more multiracial, but that's in the recent years.
Now it's starting. So
can I have a question for Lawrence, since we're panelists together. I totally agree on everything you've said about the, it's just in the data. There's no real debate about the overrepresentation of Blacks and Hispanics in COVID deaths. What do you make of, and the data seem quite robust, at least with Hispanics, that Trump is doing better in 2020 than he did in 2016 with some minority groups? There's some evidence on African-American men that, 538 was highlighting, but the evidence on Hispanics seems like it's being reported everywhere. In fact, if you look at Florida, the elderly have turned against him, and the only reason it's close is that Hispanics have moved toward him. And what do you make of that in terms of how could the Democratic Party, how could people not be sort of feeling more, traditional allies of the Democratic Party not feeling even more aligned with them now? I find it to be one of the more mysterious polling patterns of 2020. I was curious if you had any views.
Well, my main view is that I believe I've seen data that says that men of every race support Trump more than women of every race.
Sure.
So I think there's something about patriarchy and masculinity that Trump is tapping into. And I think that sort of machismo and masculinity that, I'm not going to wear a mask and I'm going to do things my own way, that appeals to some men of every race, to the degree that we have patriarchy in our society as a structure since the founding with our founding fathers, right? So I think, the notion is his sense of machismo. You have Black rappers who are coming out in support of Trump, and unfortunately hip hop has been a bastion of patriarchy, structural patriarchy in many ways as well. And sort of celebration of unfettered capitalism and destructive capitalism, that I think is something that Trump appeals to people who have that sense of, go ahead at all costs. And we know men via masculinity and structural patriarchy are ones who will tap into that even more than women of every race.
And that's interesting.
We're almost out of time, and there's two questions that are quite related. So I'm going to try and bundle them together. The person comments that the politicization of the federal health agencies has been the biggest shock of the COVID crisis for me. The sidelining of the CDC, the pressure put on the FDA to approve products that had very little supportive data, even the politicization of the FEMA response. So a question is there a way to shield policymaking, at least at that kind of nitty-gritty level, from the toxic polarization, racialization that we've all been talking about? Any ideas?
This involves the whole question of normative restraints on presidential power. And we used to believe that there were norms, there were constitutional norms, there were other kinds of norms that held back presidents from using the full authority that was at their disposal. Because in the end, through the appointment power, through other powers, the president can reach deep down into the government. In fact, now with the civil service, with the elimination of civil service protections for lots of appointees, Trump, if he has a second term, will have even greater power to reach deep into the agencies and politicize even more of it. So there's no, could you put more of this into law? Perhaps, but we also face a problem with the theory of the unitary executive that probably now a majority of the Supreme Court endorses, which would really unleash even more presidential power. So we're really, I think there's a fundamental problem here, almost a constitutional problem, as to whether or not we don't have enough protections here from the discretionary authority of someone in the White House.
Okay, so Paul, we're going to let you have the last word then, because we're coming up right to 4 o'clock, and I want to make sure that there's enough time for the second half of this panel. So I believe that we're going to take a 5-minute break. Is that in the plan? Or do we want to go right into the panel since we have everyone here?
I vote for going right into the panel. I think we're going to lose. We're going to run out of time.
So we're going right into the next panel. So thank you very much, Lawrence, Ilyana, Nolan, Paul. I think that was a great discussion, and I look forward to the second half.
Okay, so having said that, let's get started. My name is Kate Ho, for those of you who don't know me. I'm moderating the second panel, and we're going to shift gears a little bit and move away from politics and talk instead about the economics of health policy. We'll follow essentially the same structure as the first panel. We have 3 panelists this time. Each one's going to speak for, I think, 5 or 10 minutes about particular topics, and then we should have half an hour for questions at the end. So let me introduce the first panelist, who's John Gruber. He's the Ford Professor of Economics at MIT. In 1997 to 98, he was Deputy Assistant Secretary for Economic Policy at the Treasury Department. Then in 2003 to 2006, he was a key architect of the large Massachusetts health reform efforts, which of course made him a perfect candidate in 2009 to 2010 to serve as a technical consultant to the Obama administration and work with the administration and Congress to help craft the Patient Protection and Affordable Care Act. So he's a great speaker to talk to us about what he thinks needs to be fixed about the ACA, including the public option, what it means, and its implications. So please go ahead, John.
Thank you, Kate. I'm going to put on some slides. I must say, if my thunder had to be stolen, having it stolen by Paul Starr was an honor. So I'll be repeating a lot of what Paul said, but hopefully adding some new wrinkles. So let me share my screen here. Okay, so I want to expand a bit on what Paul said and talk about the 3-dimensional chess we face going into next week and the week after with the Supreme Court case. Paul did a great job describing the absurdly silly Supreme Court case, but it's there whether we like it or not. So we really have 3 moving variables. We have what happens in the court case, who wins for president, and who wins in the Senate, which leaves us 8 possible outcomes. So basically, the only way, if the Supreme Court kills the Affordable Care Act, then I think it's pretty much gone unless Biden wins and the Democrats take the Senate. So the last 4 rows. Under the other combinations, Democrats, and if Democrats take the Senate, they could try to do some minor replacements. If Biden takes the presidency, but Republicans keep the Senate, there could be some small replacements and a lot of regulation. But at the end of the day, the ACA, as we know it, is largely gone if the court kills it unless Biden and the Democrats win. So just to emphasize what Paul said, it's not just Biden winning, it's both winning. On the other hand, if the ACA survives, even if Trump and the Republicans win, I don't see them taking another run at it. That was a pretty unsuccessful run they took last time. But I think it is important to remember, for those of us who cheered the failure of the efforts to repeal the ACA in 2017, remember the attempt then was not just to repeal the ACA. It was to repeal the ACA and massively slash Medicaid. So if Republicans this time took a more narrow run at it, it's not obvious that they wouldn't be able to do it. But once again, I think that if it survives court, the ACA is largely here to stay. The more interesting question becomes, what if it survives the court case, Ed and Biden and the Democrats win? That's where things get a little more interesting. That's we turn from politics to policy. What would Joseph R. Biden do? Well, his campaign has laid out three fundamental goals. The first is to fix the exchanges. What do you mean by that? What we mean by that is that the exchanges, the way we set them up under the Affordable Care Act, were not nearly generous enough to lower income, not the poorest people, they are very generous to the poorest people, but just sort of people between about 150% the poverty line, and even some people well above median income, above 4 times the poverty line. The exchanges did not do enough to make insurance affordable for them. And Biden would propose to fix that in 2 ways. One would be to cap the percent of income people have to pay for their insurance on the exchanges, 8.5% for everyone. Remember, the way the exchanges are set up now, there's a cap as a percentage of income that rises with income. It starts at 138% of poverty and goes to 4 times poverty. But once you've hit 4 times poverty, that cap goes away and you simply pay whatever the prices are on the exchange. Due to the mandate going away and due to various set of actions by the Trump administration Republicans to undercut the exchanges, the unsubsidized prices on the exchanges are essentially unaffordable. And as a result, almost no one buys insurance at the exchanges if they're not subsidized. That is, the action the last 4 years have essentially killed the protection the Affordable Care Act provides for those above 4 times poverty. Biden would address that by saying he would cap what people have to spend all the way up the income distribution, not just till 4 times poverty. Another issue with the Affordable Care Act is that the protections against out-of-pocket costs are not strong enough. Part of that's because we take fairly low-income people and default them to a plan, a silver plan, that's a very high deductible plan. Biden would change that by defaulting people to a gold plan, which offers much more protection. So that's the first element. The other 2 elements are the one Paul Starr mentioned, introducing a public option and extending Medicare to age 60. I'll come back to them. But let's talk about the first option because A, it's much more politically feasible. You don't need to get rid of the filibuster to do it. You can just do it with 50 votes. So if Biden gets the presidency, Democrats control the Senate, they can do these 2 things quite straightforwardly. And B, it's really, really important. So to see this, let's turn to a little data. Here is a simulation that I've run, which shows for different income groups, what percent of the income group has to spend more than 10%, 15%, or 20% of their income on the combination of premiums plus out-of-pocket costs. So I sort of simulate expected out-of-pocket costs. And based on that simulation, I sort of have a distribution of what people spend. And what you see here is basically below 150% of the poverty line, people are pretty well protected. But once you get above 150% of the poverty line, in particular, once you get above 2 times the poverty line, those protections get quite weakened. In particular, between 2 and 4 times the poverty line, huge shares are spending more than 10% of their income, and non-trivial shares are spending even more than 20% of their income. Then the really striking thing is when you get above 4 times the poverty line, all hell breaks loose. If you want to be in the exchange above 40% of the poverty line, a full 1/3 of those people have to spend more than 20% of their income on premiums plus out-of-pocket costs. Even above 5 to 6 times poverty, those numbers are big. What would Biden's plan do? Keep this graph in mind and watch these numbers fall. This is what Biden's plan would do. Okay, first of all, note there's a dramatic reduction in the share of people who have to spend more than 15 or 20% of their income, and individuals who have to spend more than 10% of their income. A dramatic reduction, in particular at the very top. Suddenly, exchange coverage becomes affordable for those above 4 times poverty. Now, Biden's plan does have the interesting feature, it becomes a little regressive in the sense that the richer you are, the better protected you are. And so I would argue we should make some changes to the Biden plan. In particular, I think that income cap should be higher at higher income levels. And if you see, we still have quite a few people spending a lot of their income between 2 and 3 times 200% of poverty. I would try to do more for that group. But the important lesson here is the dramatic change that Biden's plan would make. And I think that's just not getting enough press as we all talk about the other options, which are the other aspects, which are the public option and the age 60 expansion. So let's talk about the public option Medicare expansion. The politics is difficult. I think Paul Starr is right. But I think we have to remember the public option is not a homogeneous thing. In particular, we distinguish between the public option heavy and the public option light. The public option heavy is what Jacob Hacker originally suggested, and what I think many on the left have in mind with the public option, which is Medicare as an option on the exchange. Okay, but the public option light is simply the federal government sponsors some nonprofit competing insurance plan, in particular, doesn't regulate the rates that insurance plan pays to providers. That's the key difference here, is not, there's two aspects to public option. It's having a public insurance plan, but also will you regulate the rates that plan pays to providers. The light option, I don't think a huge amount of opposition to. And the light option has the advantage that as long as it exists, you can roll in those low-income individuals in the non-expansion states. The big fight's going to come if you try to go to the heavy option, because then the insurance company is going to go to the mat. The insurance companies will go to the mat, and they are a $1 trillion industry, and they are heavyweights. So I think the real interesting issue is going to be, where do you end up between fully paying Medicare rates, which insurance companies will say, look, that's going to wipe us out, you can't do that, to non-regulation, which is going to be highly disappointing to those on the left who support a public option. There's other sort of technical issues. One Paul Starr raised, which is how do you enroll those in a non-expansion state in Medicare when Medicare is a fully nationally paid plan? How do you even coordinate Medicare with the existing exchange plans? The existing exchange plans look nothing like Medicare. Indeed, existing exchange plans in many ways are much more generous than Medicare. They have capped co-insurance, and Medicare has an uncapped co-insurance, et cetera. So how do you even coordinate that? Moreover, are we talking about a free Medicare expansion or Medicare buy-in? And how much, what are people going to pay to buy in? And in particular, if you're going to buy in, at some point, it's sort of like, why are we even bothering relative to the ACA, which gives affordable insurance for older individuals, especially under the rest of Biden's plan. And then this just comes back, then we just end, once again, we start with this politics, which is, can this all happen with the filibuster in place? And these are changes which are not purely financial. So for the, remember, to get some of the 50 votes in the Senate, they have to be purely budgetary changes. These are not purely budgetary changes. So the Senate parliamentarian is likely to reject doing them under the filibuster. And so the question is, would you get 60 votes? Indeed, could you even get 50 votes? If there's only 51 or 52 Democrats in the Senate, some might not go along with a public option heavy or expanding Medicare age. I disagree with what Paul Starr said. I think elders are going to dramatically oppose, for the very reasons Ilyana said, elders are going to dramatically oppose the expansion of Medicare to age 60. I think they'll be very upset about that for exactly the reasons Ilyana said, because they're afraid it's going to weaken what they have. So I think these are going to be real political challenges. So my bottom line is, let's not lose sight of the part that I think Biden and the Democrats could accomplish, which is dramatically improving the coverage provided by the exchanges. And I think we're in for a fight on the rest. Thank you.
Terrific. Thank you, John. So our second panelist is Sherry Glied, who's the Dean of the Wagner Graduate School of Public Service at NYU. She was previously Professor of Health Policy and Management at Columbia University's Mailman School. She was Assistant Secretary for Planning and Evaluation at the Department of Health and Human Services in 2010 through 2012. And before that was Senior Economist for Healthcare and Labor Market Policy on the Council of Economic Advisors in 92 to 93. That's under Presidents Bush and Clinton, and participated in the Clinton Healthcare Task Force. So she's also terrifically qualified to be on this panel, and she's going to talk a bit about healthcare prices, I think. So please go ahead, Sherry.
Okay, great. Let me see if I can figure out how to do this. The slideshow from current slide, right? I know what I have to do, and I have to swap. Yes. Okay, do you see it? Do you see my slides? Do you all see my slides? I can't hear you.
Yes, we see them.
Okay, good. All right. So I'm going to actually pick up on some things that John said and Ilyana said and Paul said, which is a new way of thinking about public option and everything else in health policy, which is really focusing on prices. And that is really a new direction in a lot of policy. It's actually not something that we talked about in designing the ACA almost at all. So here we are 12 years later, and instead of thinking about all the other dimensions of a healthcare policy. There's just been a lot of conversation, even in our discussion today, about prices and thinking about things like the public option as a vehicle to control prices, price regulation in the public option, regulating out-of-network prices. Why? What's happened? What has changed? So I just want to talk a little bit about that. And I'm going to sort of say there's 4 factors. The first one is something we already knew, which is international evidence. A second one, which is that nothing else works. A third one is new evidence, and then I want to talk a little bit about COVID at the end. So I'm just going to start with old evidence. Well, what we sort of knew already. This is a slide about different countries, their healthcare spending and male life expectancy at age 40. Just going to show you 2 points in time. This is 1976. You can see the US spends about the same amount as other countries. And this is 2016. So US spending has just skyrocketed. Other countries all spend roughly the same amount. We spend way more. We're not doing any better. It doesn't, it's not very encouraging or in terms of the US healthcare system. And the question is, well, why? Why is the US so expensive? This is a conversation people have been having for a long time. And, a couple of ideas people throw out there is worse health endowments. It's excessive utilization because of what economists call moral hazard. We have too much insurance. People on the left say it's too high administrative costs. I'm just going to run through a few of these very fast, but no, it's not obesity. We are fatter than everybody else, and we're getting fatter than everybody else, but everybody else is getting fatter too. And you can't actually use that to explain the differences. Australia, which does really, really well in these comparative statistics, has the second worst increase in obesity after us. It's not smoking. We do better than Europeans on smoking. We don't use more services than other people. We use fewer services than other people. That's probably not it. And if you take the administrative cost piece out of it, it's still a huge differential. The administrative cost piece is that little piece on the top, the orange piece. You can see that even if you throw the orange piece out, we're already really expensive. So it's not, I could throw up many, many other of these explanations. None of them explain things very well. We also can't keep going the way we've gone in terms of the policies we have used. We can't, the strategies we've used to try and control spending have mostly focused on the utilization side. And we've tried to focus on it in 2 ways. First of all, by raising cost sharing. And John talked about that with respect to the exchanges and what a disaster that's been. But we're not going to do any more of that. We have people are already pained by paying medical bills. Deductibles are out of control. We can't go any further to control our national health spending with just pushing on utilization on the cost sharing side. And the big hope in the Obamacare legislation is that we could do this by changing the way we pay providers, that we could make changes in methods of payment like accountable care organizations. And the jury's in now on those, and like you can save a teeny little bit of money, like 3% or 5% of Medicare spending. That doesn't, if you look at remember those pictures that I showed you at the very beginning about the US, like 3 or 5% of Medicare spending is not really almost worth thinking about. So we go back to like Uwe Reinhardt way back when saying, maybe it's none of that. Maybe it's really the prices. And we can come back to why it might be the prices, and particularly the private prices. So these are relative to Medicare and relative to private prices in other countries. And you can see relative to Medicare, other countries are not that radically different. Relative to private prices, it's really pretty strikingly different in terms of the cost. And what's really, I think, interesting about this is that in general, the US is not a high cost country. So you can't say it's just because we're really expensive, because we're not really expensive compared to the cost of living in other respects. So we see the international experience, we see that other things are not working. Then there's a load of new evidence that's come online. The first big piece of it actually was around surprise billing. I never heard of surprise billing while I was in Washington. It wasn't actually an issue. When I came back in about 2013, Elizabeth Rosenthal started publishing these pieces in the New York Times saying people are going to the doctor and discovering that they have really good insurance and discovering that they have an enormous amount to pay, and putting a different valence on it than had been there before. It had always been the fault of the insurance companies that you were paying all this amount. But now you see this headline, you're going in and it's the doctor who's giving you that bill. It's the emergency room, the guy who's seeing you in the emergency room who's giving you a bill even though you went in network. And she's sort of saying it's not your insurance company's fault, it's something else. And so we start to see this conversation around how much are people being charged to go out of network. And then there's a host of new literature that comes online. I'm only going to show some stuff from Zach Cooper, but there are lots of other people who've been looking at this, just looking at the difference between how much Medicare pays for things and how much private insurers pay for things. And I think even more compelling, this is total private spending per private beneficiary and total Medicare spending for Medicare beneficiaries. The reason spending for Medicare beneficiaries varies across the country is because of differences in utilization, because Medicare pays the same amount wherever you go. What Cooper and others show is that the reason that private spending varies is not because of differences in utilization, it's because of differences in the prices paid. And so people start to think about, well, what are those differences in the prices paid? And it turns out the most interesting part of that isn't even the prices paid across the country, but the fact that within the same market, you are seeing radically different prices paid for the same service among hospitals in the same market. And actually, you can go even further within the same hospital by different insurance companies. So these strikingly different, huge differences in prices. And I just want to give you, end by just talking a little bit about what this means with respect to COVID, which I think has really nailed this problem even further, which is, so this is how much you get paid as a hospital for a COVID-like hospital stay. By private insurers, Medicare, private insurers, you see that huge variation, right? Because different private insurers pay different amounts by Medicare and by Medicaid. So the same care provided in the same hospital to the same condition, and this very large difference in the prices. Well, there's been this long conversation in the health services literature that says that those private prices are high because they're subsidizing the Medicare and Medicaid prices, this phenomenon called cost shifting. There's been all this discussion about cost shifting and academic papers about cost shifting, blah, 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 right? But here's the striking fact. This is New York State, because that's what I've got. And this is the share of discharges from the hospitals that are privately paid. And what you see here is it varies substantially. Some hospitals see only private patients, almost exclusively private patients. NYU is way over there on the left side at like 60-something%. And some hospitals see no private patients at all. So there's not cost shifting happening between NYU and those hospitals at the other end. They each run their own businesses. And so this whole argument that high private prices are somehow subsidizing low Medicare prices, Medicaid prices, doesn't make sense when the people are not in the same hospital. And we see this when the CARES Act happened and you start to see relief funds for hospitals, and you can see that the hospitals that were doing really well and have lots of privately insured patients, they were getting those high prices. They got the most money in the relief funds because they were the ones who lost the most revenue when they shut down. But this is my last slide. Okay, so the hospital in the black on the far right-hand side here is Elmhurst Hospital. It's the hospital that was hit the hardest when COVID happened in New York City. Only 12% of the patients at Elmhurst Hospital are privately insured. So if you think about how much revenue flows into that hospital, it is very, very low relative to the hospitals that are serving mostly privately insured patients. And we're beginning to get the sense that part of the reason that people did really poorly in those hospitals is that they just didn't have enough money compared to the better equipped hospitals. And so that's not about utilization, and it's not about cost sharing, and it's not about the things that we were in administrative costs or any of those things we worried about before. It's really about how much should places be paid for providing the same service, and how much should different insurers be paying for providing the same service. And I have to say, I don't actually know the answer to that question. I'm still struggling with it, but I am really struck by how the conversation in health economics, health policy has really shifted in this direction. And even health economists I think of as being someone on the conservative side are starting to talk about what we need to do to be regulating or thinking about healthcare prices, not only quantities. So let me stop there.
Thank you, Sherry. Terrific. Our third panelist is Amitabh Chandra. So Amitabh is professor at Harvard University. He has joint appointments at the Business School and the Kennedy School of Government. He's a member of the Congressional Budget Office's panel of health advisors. His research focuses on innovation and pricing in the biopharmaceutical industry, as well as on medical malpractice and a bunch of other interesting issues. But he's going to talk today about incentives for innovation. So go ahead, Amitabh.
Thank you, Kate, and thank you everyone for inviting me to this great symposium. I'm going to try to take the conversation in a slightly different direction. You know, I think in health policy, we spend a lot of time talking about coverage and, you know, out of pocket, because those are things that really weigh heavily on people's minds. So I think it's correct to start with that. But at the end of the day, one reason that it's always so hard to cover people is because there's new medical innovation. Like, it's very easy to sort of give people 1990 health insurance and keep it at 1990 health insurance. You know, even if we insured everybody in 2020, something new would come along and probably raise prices, raise premiums. And I'm going to argue that we actually want these new things to come along. So I want to talk about what sort of incentives we have for innovation. And I'll just start with Alzheimer's, which sort of, you know, highlights the need to think about new medical innovation. So Alzheimer's, you know, huge disease, so it's not a rare disease. Massive cost. The direct cost of caring for Alzheimer's is about 160 billion. If you add the value of, you know, caregiver time, and you add the emotional costs and things like that, you get estimates that are somewhere between $400 and $500 billion per year, just in the US alone. So huge disease in terms of like lost, you know, quality of life, direct financial spending. We don't have anything good for Alzheimer's. Like, we don't have good drugs for Alzheimer's. And it's not just that they aren't in phase 2 or phase 3, they just don't exist. The basic science isn't really there to give us great drugs. So if you think about the very bottom of my slide, what we want for Alzheimer's is 3 types of prevention, right? 3 types of innovation. We want to figure out how to prevent Alzheimer's, which may not require a drug, but the incentives to figure out how to prevent Alzheimer's are actually quite weak. It's going to be very hard for a company to capture any of the social value associated with novel prevention. So if the prevention was, you know, suppose we found that more sunlight or better sleep reduces Alzheimer's, it's not a patentable thing. I doubt anyone will find, there might be very simple things that reduce Alzheimer's, and my guess is we'll never find them. If we find them, it'll be completely by chance, which is not a good recipe for such a costly condition. I think we need to be able to diagnose Alzheimer's better and sooner. So we need incentives for that, research on that. And then what I was talking about a little bit was treatments, pharmacological principally. But I think we need other kinds of innovation as well. I mean, one of the things that we don't talk about a lot in this desire to expand Medicare to other people and the public option is just the catastrophe that awaits most families because of an incomplete market around long-term care, right? That market, that private market doesn't really exist, and to the extent that it exists is very, very small. I think economists have done good work trying to understand why that market doesn't exist, but this is a market that we have to grow, right? This is a huge problem. In addition to long-term care insurance, we have to sort of figure out what to do about nursing home quality, and we've learned what a disaster that is as a result of COVID. And nursing home quality is not going to be fixed without thinking very hard about the workforce that staffs those nursing homes, which can't be separated from immigration, right? So again, I think we need innovation, and it's not just pharmaceutical innovation, it's innovation in, you know, different forms of insurance, new kinds of markets for long-term care. I think that we need a lot of innovation in thinking about how all the constructs that economists use to make sense of markets, choice, demand, rationality, you know, the weak and strong axioms of revealed preference are all violated when you're dealing with patients who are in cognitive decline. This isn't even like behavioral hazard. This is like sort of like, it's not clear what the demand curve looks like. And so how will markets respond, markets for healthcare respond to a growing number of people who are really not in a position to act like the consumers that we are used to modeling all the time? So I don't think we've done a lot of that work. Let's talk a little bit about the incentives for the drug side of things for a little bit, and then we'll come back to long-term care 5 times. This is Heidi Williams's research. So I want you to focus on the graph on the right. she makes this really important point that if you look at where the clinical trial activity is, a lot of it is in late stage cancer. About 18,000 trials for recurrent cancer, 12,000 trials for metastatic cancer, 523 trials on cancer vaccines. And her point's a very simple one. Her point is, look, at the end of the day, the patent clock starts ticking as soon as the trial starts. So I, as a for-profit company, have no incentive to do clinical trials over here in cancer vaccines because my trial is going to last so long that it eats into the patent life. I have a much stronger incentive to go into an area of medicine where I can do a 3-month clinical trial or a 4-month clinical trial. Now, this is going to be incredibly important for Alzheimer's, because if you want a transformational drug for Alzheimer's, one that reduces the onset of dementia by 5 years, I need to show that it reduces the onset of dementia by 5 years. I'm going to have to do a very long clinical trial, and I won't have patent life left at the end of it to do it. So I think a lot of Heidi's thinking around insufficient incentives for transformational drugs apply to Alzheimer's. And I think this is a conversation that we're really not having right now. I think at the same time, we have too generous incentives. Right, so I just talked about insufficient incentives for Alzheimer's, but if you look at the portfolio of what the FDA approved recently, half the drugs over here, 50% of the drugs that were approved were orphan drugs. Half the portfolio is orphan drugs, right? And it's not clear, a lot of the work that I've done with others suggests that the incentives to make these orphan drugs are necessary, but more necessary than we need them to be. So we might be incenting inframarginal. These are drugs that have come to market even in the presence of weaker incentives, right? Zolgensma, for example, this is the world's most expensive drug, is a gene therapy for SMA. It's $2.1 million. If you kind of look at the spreadsheets that the VCs who invested in Avexis had put together, they weren't expecting a launch price of 2.1 million. They were expecting a substantially lower launch price. So that innovation would probably have come to market at a lower launch price. So now we've got a situation where we've got insufficient incentives for some drugs, too generous incentives for other drugs. In addition to that, we've got a world where a lot of drugs are just not going to go generic ever. I mean, some of these orphan drugs are for markets where you only have 500 to 1,000 patients. These are natural monopolies. One establishment can probably meet the total demand. And we see evidence of that already. If you look at non-orphan drugs approved through 2011, about half of them had generic competition. If you look at orphan drugs approved through 2011, only about a third of them had competition, right? And I haven't even got into the ultra orphan. So I think we have to think far more aggressively about how we regulate the prices of ultra orphan drugs. We'd have to use a lot of natural monopoly regulation theory to do that. But I don't think we've started to do that. I think our conversation is very blunt. It's sort of pharma good or pharma bad. And I think this is a much more complicated problem than pharma good or pharma bad. Pharma can be very good, but it can be very bad if we let a manufacturer be a monopolist for an infinite amount of time. And that person will be, even if the patents expire. So that's something I think we have to think about. So those are all pull incentives. I want to talk a little bit about push incentives. We spend as a country very little on science research. The budget of the NIH is about $35–40 billion. It's about 0.2% of GDP. And increasingly what Congress has been doing is it's gotten very excited about giving money to disease institutes. So we're going to create the NCI, give money for cancer. We're going to do research on Alzheimer's, and maybe that's $2.5 billion. The point about transformational drugs is that we often just need to understand basic biology before we understand the disease. And so giving money to the NCI might not actually unlock the actual mechanism behind Alzheimer's or the actual target behind a novel therapeutic for Alzheimer's. Maybe the novel target for Alzheimer's is regenerative medicine. So we have to figure out how to reprogram the stem cells in your bone marrow to regenerate as neurons. That insight is not going to come from a National Institute of Alzheimer's because it's too downstream. They're going to spend all their time studying tau and beta amyloid. And what you need is much more upstream research on how you reprogram the stem cells of a zebrafish, which has nothing to even do with human beings. But if we did that, maybe 30 years later, we would get something amazing for Alzheimer's. So I think even on the push incentive side of things, we aren't really thinking seriously about how to do this, other than to say things like give the NIH more money, which I think is very, very blunt. I think we should be thinking about exactly how we fund a lot of this push research. And I think here the work of people like Leila Aga and Daniel Lee and Pierre Azoulay is incredibly important as we think about this challenge. I think all of this will come together, again, back to Alzheimer's. This is a graph I'm going to close with. These are the failure rates associated with drug discovery for hepatitis C, for Alzheimer's, for MRSA. You can see for Alzheimer's, we don't, first of all, let me just start by saying we don't have good drugs for Alzheimer's. We just don't. So even if you look at the bad drugs for Alzheimer's, for every 200 drugs that started drug discovery up over here, so this is like research in a petri dish, one of them was approved by the FDA. This was not a transformational one drug. This was just a lousy one drug. Look at the incredible failure rates between preclinical and phase 1. This could all be solved by basic science. Basic science could really de-risk a lot of this, which actually would induce much more capital to come in. So that's one piece of it. But there's a lot of failure between phase 2 and phase 3 as well, right? That isn't basic science. That's the translational science. That's not having good animal models of the human brain. Often we learn in the clinical trial that, you know, the drug was unsafe, and that's why we stopped the clinical trial. So here a disease-specific focus could help, you know, kind of do this innovation. But, you know, look, at the end of the day, if you're sitting in a VC environment and you're looking at this failure rate, you're not going to invest in Alzheimer's, and society will continue to spend $400 billion to $500 billion a year dealing with Alzheimer's. So I think it just illustrates the importance of medical innovation. In my comments, I focused on pharmaceutical innovation, but I don't mean for us to lose sight of the fact that a lot of the innovation that we need is actually innovation in thinking about how to prevent Alzheimer's and the extent to which that might actually be non-pharmaceutical. I'm agnostic about that. But there are very few incentives for that. There certainly hasn't been in the political debate a conversation about long-term care and the fact that despite the great appetite for Medicare for all, there is no long-term care in Medicare for all. Like if there's a payer in the US that does the best on long-term care, you know, full props to Medicaid on that. So I think we have to think actually much more about spending more on healthcare, not less, to take on some of these problems. Let me close with that. Thank you, Kate.
Terrific, thank you. So that's raised a large number of questions to think about and talk about. Let me read out one question from the audience, which is around employers. So healthcare is a huge administrative and financial burden for most employers. Why don't we see more of them lobbying Congress hard for a single payer or a government-run health system? John, I wonder if you have thoughts on that, Sherry.
Hamlet? We prefer the evil we have than to fly to others we know not of.
Well, John, you're muted, I think.
Oh, sorry. This is a question that predates even my entry into grad school. This is the oldest question, which is, gee, it seems like this would get a big burden off employers. Why wouldn't they want this? And I think that it's just general tribal conservatism among business owners. I just don't. I mean, I think that they just are worried that if you take that, you know, if you have government-run healthcare, you might have government-run other things they might not like. I really don't know. I haven't really seen a good theory that's not politically motivated for why employers wouldn't want this. I guess the only other remaining option would be the people who are the employers are rich and they know that a single-payer system would be progressively financed, and so they'd bear a disproportionate share of it. So that could be the one sort of, you know, economic argument.
Okay, great. Thank you.
I think part of it, I mean, I also think part of it is our conversation in the U.S. The U.S. is very strange in this way. We have this argument, which is either everybody's going to be in the same system, or we're going to be in the very fragmented system we have now. Many of the European countries have sort of, and Australia have sort of accepted the idea that you're going to let the 10% of business owners or whoever it is out, and they can get their care tomorrow if they want it. We just find that really hard to somehow politically swallow. But if we did, I think that might actually reduce business opposition to.
I mean, to be fair, Bernie Sanders said he wanted to ban private insurance, everything but plastic surgery. So he would respond to that narrative. And I agree. I think, Sherry, we have to recognize that, you know, there's no purely public system anywhere. There's always private opt-outs. And I think it comes to this general inability of American politicians to say out loud, we have a two-tier healthcare system. And the question is just which two tiers we want to have. Right now we have two tiers, which is those with insurance and those without. We can have a different two-tier system where everyone has health insurance, but rich guys have better health insurance. But we're always going to have two tiers. And we just have to own that and decide, does society want to pick what the two tiers are, or just let the market decide what the two tiers are? And I think politicians are willing to say that.
Can I ask the question that I was going to ask? I think I sort of posed it in our part of the talk. And I guess it's mostly to Amitabh, but it's to any of the three of you. I've been always told that I can't have universal health care or Medicare for all in the US because we would lose the innovation that's, you know, so American and so great. So here's a great test. We're all trying to figure out how to manage COVID with technology, with, you know, improvements in just protocol and treatment. And what is the evidence on like how in the last 8 months, the American medical technology sector has performed? And I mean, I'm very cynical, but I'd love to hear evidence that we've done better than other countries, whether it's testing, you know, rapid testing, vaccines, of course, or just, you know, drug treatment. Have US, you know, medical technology companies done well so far in the, you know, 8 months baptism by fire that we're all experiencing?
Well, I think that narrative, I think, is false, that because we spend a lot, it's all going into innovation. Like a ton of it is just going into rents, right? A ton of it is just going into rents. A lot of it is just capture by the industry too. So it's not all innovation, number one. On the innovation, I think the US does extremely well, or not the US, but companies geared towards the US market do extremely well in responding to the incentives that the US provides, which is to do like rare disease innovation and things like that. They do a lot of that. We don't really have generous incentives to build drugs for viruses, which is the whole reason that when COVID showed up, there was nothing on the shelf. Now, if you look at the fact that in 8 months, who's ahead of the race, it's sort of between Pfizer and Moderna, right? Now, I'm not going to say that American companies, I think it's easy to say that American companies because they're in the United States. I think even if you're dealing with a German company, ultimately, a lot of these companies are geared, focused on the US market. So I think that like, I'm sort of uncomfortable with this idea that it has to be an American company. I think all companies in the pharmaceutical space are looking at the US market, and all of them were not prepared for COVID-19 because nobody thought COVID-19 would hit the United States. But like when Ebola hit the United States, so there was some threat that Ebola would hit the United States or could, Merck produced a vaccine. It was approved last year. We have a vaccine for Ebola. So I think there is truth to, like, you know, when people get worried about the US catching a cold, that's when the innovation starts. And that's why we have 48 companies searching for vaccines. It's because, you know, Uncle Sam has COVID now. But we weren't that worried about it when it was in Wuhan.
I would say though, go ahead.
I think that's right, Amitabh, but I think, you know, if you look at why we have all the vaccines now, partly it's because of Operation Warp Speed and because of the money the government's put behind it. And I think the answer is, Ilyana, when there's a public health crisis, when it's a public good, you need government R&D. And, you know, Simon Johnson, I've written a book arguing for more government R&D, and I think this is a classic case for where you need it. And I think the private sector is very good at innovating when the returns can be captured by the private sector. And that's led to great innovations. I don't want to dismiss what it's led to, particularly in pharmaceuticals. But when much of the returns, as Amitabh was saying with Alzheimer's, are captured by society, that's only going to happen with public investments in R&D. And I think we need more of it. Now, it can be in partnership with the private sector, and the private sector has a lot to offer. But I think as Operation Warp Speed shown, the public sector's got to lead.
And Ilyana, last bit. I think the other piece that's really interesting is dexamethasone, which is probably the most effective thing we have right now for COVID, came out of the fact that the NHS in Britain was able to actually do the research in a way that we would not have been able to do it. So to the extent that this is repurposing things that are not on patent, that's something we will be very bad at in the US.
Yeah.
If there are solutions to this that are not new patents, we will never find those.
Yeah.
Thanks.
There's a comment from the audience along the lines of the US did well in terms of developing a wide variety of diagnostic testing relative to China or Germany, perhaps. So that's an interesting side.
Yeah, the great irony of diagnostic testing is that if you think about the basic science that led to the PCR test, right? The kind of gold standard, all of that was developed in the United States. We're just not very good at then figuring out how to take that and produce kits with it in the absence of a market signal. But we're just not good at that.
Okay,
and
let me
I wish
ask you.
that on something like testing, we could have solved this. I mean, this is what governments are good at doing, right? They're good at solving market failure. Government could have stepped, I think under another administration, the response on getting more test kits developed, maybe by the Army Corps of Engineers or whoever, would have been probably nationalized or federalized.
So let's move on to a different question from the audience, picking up on Amitabh, your comments on long-term care. So the question is there any model the US can look to when thinking about what benefits a federal long-term care program could provide, who should have access and how to finance it? Models might come from other countries or state Medicaid programs, or maybe the VA system. Do you have thoughts on that, Amitabh?
No, I think John would, but my instinct on answering these questions is it's much easier to learn from state Medicaid systems than to learn from another country. And I also want this program to be means tested. Like, I think rich people should pay for their own long-term care. It doesn't have to be for everybody. It can be for people who are below 400% of the poverty line.
You know, I think I am hoping that among the many, many priorities that the new administration will deal with, if the election goes the way it's expected to go, one of them we're revisiting long-term care in America. Now, I think there's two components we have to separate. One is the financing component and one is the delivery component. On the financing component, you know, it's not, what we have now is essentially finance long-term care by an asset tax. We essentially say, if you reach your nursing home with any money, we're going to take it all away and the government will pick up the rest. What was proposed in the ACA and other people have proposed is a social insurance model where people pay while they're young and then get benefits when they're old. It's not actually entirely clear which one's better. The asset tax is pretty redistributive. That's a good feature, but it's distortionary on savings. So that's a tougher one. I think financing, I don't actually see that changing. Amitabh, I don't see a big growth in the private long-term care insurance market. I think we're going to sort of keep that financing system. I think where the real changes could happen are delivery. And in delivery, there's sort of, if you really crystallize for me talking to someone about their parent, which is, think about yourself as, you know, you're someone my age, you've got an elderly parent, they're failing, you've got to decide what to do. Here's two options. One is you can say, I'm going to figure out how to keep them at home, out of a nursing home. That means I have to figure out who to get help from, when to get it, how to get them their meals, how to get them to make sure the heating stays on, how to make sure they can get all this stuff. Option two is I can put them in a nursing home and that's all taken care of. Now, I don't like it, it's crappy, they're unhappy, but you know what? They do it, it's one-stop shopping. The question in America is we need to move to a system where there's one-stop shopping for many options, not just the most expensive option. And that's something, you know, quite frankly, candidate Biden's talked about. And I think that we need to get very serious about. We do need lots of things to improve our nursing homes. But honestly, for many people, nursing homes are the right option. Just for many people, they're not. And we need to figure out a way to have more available non-nursing home options.
So a lot of the work in this area is also about trying to come up with measures of functioning and disability that allow you to allocate care in public programs appropriately. And that becomes much more complicated when the thing you're delivering is less unpleasant. So it's not that complicated when it's a nursing home because nobody wants to put their parent in a nursing home if they can avoid it. But when it's home care, it's really critical to have ways of assessing exactly how much care people need. The moral hazard there can be really big. And that's something people work on. It's also something people should work on more.
Terrific. Sherry, I have a question for you. You were very compelling in terms of explaining that prices are the problem for spending. What do you think is the solution? Is it all about antitrust enforcement? Has that been a failure? Do you think a public option would help? Or what else should we be thinking about?
I think there's been a lot of focus on antitrust enforcement and a lot of focus on consolidation in the healthcare system. And that's a very legitimate issue and a legitimate focus, but it won't solve most of the problem. There are a couple of reasons for that. One is there are real economies of scale in different parts of the healthcare system, hospitals and so on. And there are a lot of markets that just are not going to support 4 or 5 competing hospitals or health systems. And so you cannot actually have competitive systems in a large part of the country. Maybe as much as half the population of the country lives in places where competing neurologists, competing high-tech hospitals just are not a plausible reality under any antitrust regime. So I think that is a real limitation that we need to keep thinking about. I think I am gradually coming to think that expanding the set of people who benefit from regulated prices is a good idea. How we do that exactly, I think there are different strategies for doing that, including regulating in markets versus in kinds of products. I don't know. Some people have put forward the idea of regulating those markets where competition is not feasible. That's one strategy. It's a little hard to do it. Another is to give people an option that has regulated prices and let them get out of it if they don't want to be in that system. I think there's a lot more to be done around that, and I think there's a lot of economics thinking that needs to go into it. We haven't actually. It's such an uncomfortable place for economists to be thinking about the idea that prices are not right, and that we don't know why they're not right beyond concentration. And like Zach Cooper's work says, like when you have one hospital, prices are like 15% higher than if you have 5, but 15% is such a tiny share of the unexplained variation. Like there's a lot more to it than that, and we don't understand it. So I think all the smart economists on this call need to get working on this.
John, you have anything to add?
No, I just feel like Sherry is literally reading my mind, which is literally, I used to say, well, it's not time for regulation yet. Let's figure out we can do this to competition. And then I slowly, my defenses fell until about 3 or 4 years ago, I said, forget it, we got to regulate. But then I don't know how to do it. So I think Sherry's exactly right. The market, Ken Arrow said it in 1963, and it's as true now than it was then. The market does not work in healthcare. We need to regulate. But, we used to, in the 1970s, regulate hospital prices in virtually every state in America. And virtually every state got rid of it because it was such a disaster, because the regulators did a terrible job. Sherry, am I misremembering my history?
I think you're right and not right. So I've been thinking about this a lot. So one thing is there are parts of the healthcare market where competition seems to work okay. Primary care prices are low. They're not actually higher than they're not a lot higher than in Medicare, even in the private market, because there's a lot of entry and there are a lot of people. And so you actually have the possibility of entry from nurse practitioners. You have a decent amount of competition. It's okay. What happened with hospital regulation in part was that the DRG system created this big increase in hospital capacity, and PPOs and HMOs came in and wanted to undercut the regulated prices. And where they could, which is like in California, they started to do really well. And so the consensus behind regulation fell apart. It wasn't just that the regulators were doing a bad job. It was actually that with excess capacity, the private market, when you have excess capacity and when you have easy entry, private markets work fine. But when you don't have excess capacity and you don't have easy entry, like there's nowhere to go.
Great point.
Good points. One of the questions that's come up bring this back to drugs and innovation. There's a comment, orphan drugs are priced high exactly because the market is small. How else can we provide an incentive for development of such drugs in a capitalist structure? Is there any answer to that beyond we just have to spend a lot of money on some of these?
No, I think what we should talk about is what happens to, I mean, fundamentally, the incentive we have is a very blunt incentive. Regardless of the quality of the innovation, the company gets 20 years of patent life. That's a very blunt way to induce innovation. We got the 20 years from where? We got it from the Venetians. They made up that number in 1650. We used the same number in 1790. We're still using the same number today. It's crazy, right? It's absolutely crazy. If I make a small manufacturing tweak to a drug, I can file for a new patent. That also gets me 20 years of patent life. So I could invent Sovaldi, 20 years of patent life. I could figure out a way to make Sovaldi taste good. That also gets 20 years of patent life. Like, that's just crazy. I think the problem with so I'm not saying get rid of the patent system, but I do think we have to think about the regulation of natural monopoly. So it's analogous to this point about hospitals. Some of these orphan drug markets are markets for drugs where no more than 500 or 1,000 patients need the drug every year. No generic entrant will ever come in, even 100 years later. No biosimilar entrant will be willing to absorb the fixed costs of entry, because at the end of the day, there's a natural monopoly. One establishment can deliver to the entire market. I think we have to think in those markets about old-fashioned marginal cost regulation, which is actually not that hard to do. We don't know how to do price regulation of pharma companies, but we do know how to do cost regulation of companies after the patents have expired, right? So what we could say to companies is, when you guys get a new drug approved and the Orange Book lists a whole bunch of patents, those patents are going to expire on this date. You are free to add new patents and add new products and bring new products to market. But that old thing you launched, this will be the price of that old thing. Either you produce it or you have to transfer the IP to another company that produces it. And the marginal cost, for a lot of these gene therapies is higher than it is for small molecule drugs, but it's still small. It's still very small. So the cost of goods for Zolgensma is not $1 million or $100,000 or even $1,000. So this is something we know how to do, I think.
I mean, I think this really comes back to what Sherry and I were talking about, which is we have to regulate it. Look, Zolgensma is a bargain at $2 million. I mean, you're talking about a disease, SMA, that was leading to kids leading horrible lives and dying by age 2. Okay, $2 million is a very good price to pay to save children's lives. It's also more than we should pay.
Right.
And so the question is, it comes to Sherry's question. I mean, here we don't even pretend to have a market, right? At least the other things you can pretend there's some competitive force. There's no competitive force here. The other thing I'll point about Zolgensma, the thing that I think does highlight the problem, it's the only drug I know of, the only expensive drug I know of that was introduced at the same high price in the US and the UK. So it's not like Europe. Europe's got a tsunami coming they're not ready for.
Well, the Canadians
regulate the price of they may keep their doctor price low and their hospital prices low. Right. They're not prepared to deal with these drugs that are incredibly valuable, incredibly expensive. So it's not like Europe is the right answer on this one either.
No, nor a lot of these other countries. I mean, Canada, you don't get Zolgensma. They didn't even file for approval for Zolgensma. Right. So if you're an SMA patient in Canada, you got to run your own GoFundMe campaign to get the drug in the US. I don't think other countries with their public option and regulated prices are prepared for this kind of pharmaceutical innovation, where you just can't walk away from the drug.
So I'm seeing we have just a couple of minutes left. I wanted to bring us back a little bit towards the topics of the first panel and see whether any of you have thoughts about what's the problem with the policy dialogue in healthcare at the moment. Is it about politics? Is it about information? What is it that's the single biggest problem with the policy dialogue as it relates to healthcare and as is going to matter in the next couple of months?
a great question, Kate. I don't know if it's the single biggest problem, but I would argue one problem is I think healthcare may hold the record for the topic where the ratio of what people know to what they think they know is the smallest. So I'm sure we've all had the experience of getting back. We used to go in taxis or Ubers and saying, you know, if you ever say you work in healthcare, and the driver saying, well, let me tell you how to fix healthcare in America. And they often have interesting insights, but the truth is we've all studied it with our lives and we have more insights. And it's just, they don't say, when my physics colleagues walk in, they don't say, well, let me tell you about astrophysics. I mean, basically, I think part of the problem is it's hard and people don't think it's hard. And that is, well, I think that makes it uniquely challenging.
The lack of basic information is just amazing. Like the slide that Sherry showed about the reimbursements to the hospital, you know, in the Bronx, like we just didn't know, right? And we didn't know about surprise billing, and we didn't know about the differences in prices. So here we're trying to study a market where we don't even know what the prices are, right? Not because there aren't prices, but because we don't even see them most of the time. So the lack of information is really stunning.
I think
actually, well, go ahead, Lawrence.
I was just going to say, I think there are two problems. Number one, when Barack Obama passed the Patient Protection Affordable Care Act, or when he signed it, healthcare in America became not only politicized, but racialized. So you had sort of this attaching the second issue, which is also socialism, that this extreme reaction to saying we don't want socialized medicine while holding up a sign saying protect my Medicare, you know, is sort of the, you know, when you combine race and this anti-socialist sort of perspective in American politics, like that prevents, I think, the more expansive, the more radical action that needs to be taken to deal with radical problems. And
it becomes a generational fight as well.
I hate to end by quoting President Trump, but I think he actually had it right? He was the one who said, who knew healthcare could be so complicated?
Oh, Lord.
That is a great way to end this panel. I think we are out of time. So thank you to all of our participants. This was a terrific couple of hours from my point of view. Thanks to everybody for being involved.
Thanks. Bye.
I'll go back to refreshing the election prediction web pages.